Just to note that Nephrology News and Issues is now part of the Helio family of healthcare publications. And as you'll see here, these include numerous other fields, including cardiology, oncology, family practice, endocrinology, and others. And NNI's new website is at www.helio.com/nephrology. And for those of you who are on the email list, it's actually a great email update daily from Helio/NNI with respect to important developments in the nephrology and dialysis community. All right, and just to note that we are on Twitter, so please feel free to join us on Twitter at DOPPS Study to tweet about today's conference and to join the conversation. So thank you. Okay, so we are always interested in making these presentations as interactive as possible. So we do welcome your questions throughout the session, and we'll pause to answer them at the end of each section. Please submit your questions using the Chat with Presenter feature, which is accessed by the blue icon located at the bottom left of the screen. So please feel free to submit questions, and then in addition, we have a number of polling questions throughout the talk, probably 8 or so of them. And these are really, there's not a right or wrong answer. We're just interested in folks' approaches to treatment practices in your dialysis unit or nephrology clinic. And of course, all your responses will remain confidential. When the poll is opened and displays on your screen, please answer the question, and then don't forget to hit the submit button. And we'll tally responses in real time and sort of speak to them after we've tallied responses. Okay, well with that, let's move on to the program itself. And we'll start with an update on the US DOPPS Practice Monitor from Doug Fuller, who is a senior biostatistician with us at Arbor Research Collaborative for Health and senior analyst in charge of the DOPPS Practice Monitor. Doug.
Yes, thanks, Bruce. I'd like to start off by just giving an introduction to the DOPPS Practice Monitor, available at www.dopps.org/DPM. That will take you to our U.S. site. The U.S. DOPPS Practice Monitor is based on 3 large data sources of hemodialysis practice in the U.S. The 2 LDOs, Fresenius and DaVita, as well as Visionex, which is a provider of electronic medical record software, primarily serving small and independent organizations as well as hospital-based units. Combined, our sample consists of over 200 facilities in the U.S., over 14,000 patients. We're just going to show a brief summary of highlighted trends on this web conference, but the full website contains now over 1,800 figures and tables for your information and amusement. So the first section I'm going to talk about is an uptake of newer medications. This is always an interesting topic for us and those of you out in the community. The first one is going to look at calcimimetic use. This is our calcimimetic use by type graphic. Starting in February 2015 through February of 2019, we've seen a continued slow increase in the proportion of patients prescribed any calcimimetic. Prior to 2017, this was exclusively Cinacalcet, the oral medication. But beginning in 2017, we also started tracking use of etocalcetide, which is the new intravenous calcimimetic. And we can see that particularly starting in around the middle of 2018, we can see that nationally there's been an uptake of 4 to 6% of patients using etocalcetide, and this has, in large part, constituted a replacement or a transition from patients previously using Cinacalcet rather than a straight increase. Next slide. Notably, this increase has been mostly concentrated in the small Dion independent sample with just over a quarter of those patients overall using calcitide, 37% overall using any calcimimetic. And that contrasts with our large and medium DO sample, where again about a quarter to 25 to 28% of patients are using a calcimimetic, but most of those patients are still using cinacalcet at this time. Next slide. Since 2015, we've been tracking the use of pegylated epoetin beta. This is a drug that has been used in Europe for over a decade, but was recently becoming available in the U.S. And so in blue is the proportion of patients using epoetin alpha, and the yellow is darbepoetin alpha, and the orange is the recently introduced pegylated epoetin beta. And we can see that this is very quickly over the last 4 years increased the use of pegylated epoetin beta. Almost 50% of patients are now using that drug. Next slide. And sort of conversely to the prior slide on needle calcitide, we can see that the use of pegylated epoetin beta has been mostly concentrated in our large and medium DO sample, with, again, half of that sample using pegylated epoetin beta, approximately the other half still using epoetin alpha. And on our small DO and independent sample, we're now seeing, just in the last year, a pretty rapid increase up to 20% and 19% of patients using the pegylated epoetin beta. Most of the small DOs and independents are still using darbepoetin. Next slide. We've also shown that this slide is actually not updated from last year, but we also have been showing the uptake of iron-containing phosphate binders, two major products in this area right now. Since June of 2015, this use of these agents has increased from 2.4% up to 7.1% as of February 2018. Next slide. On the DPM, one of our main topic areas is dialysis dose and prescription. So we'll go through 2 slides here. The first slide is looking at the average length of a dialysis session across our entire national sample. Starting in 2010, August, which is as far back as the DPM goes, we saw a mean session length of 217 minutes, and that has slowly but steadily increased to about 221 minutes in the most recent data in February 2019. The consequence of this is we've also seen a decline in the proportion of patients having a treatment time less than 3.5 hours. That percentage has declined from 34% down to 31%. So that brings us to our first poll. The polling question 1 is, which of the following best describes the recent trend in ultrafiltration rate among hemodialysis patients in your unit? Option A is increasing, B is no change, C is decreasing. And we'll give you a moment. So the results are in. Looks like we had 15 respondents to the poll, and the great majority indicated decreasing UFR trend or no change, with 6% of respondents suggesting that their UFR has increased. And that largely matches with the data that we've shown, collected and shown on the DPM, where we have the average ultrafiltration rate was 9.4 milliliters per kilogram per hour in August of 2010. That has declined down to about 8.2%. I'm sorry, 8.2 milliliters per kilogram per hour in 2013, 14, and 15, and has continued to decline, albeit very slowly through 2019. UFR reporting is a new QIP measure, the Quality Incentive Program, that will be introduced in 2020. Facilities will be required to report UFR values for their patients. There has been some research suggesting that UFR above 13 in particular, but as well UFR values above 10 may be associated with increased mortality, and so that this will be a focus for CMS going forward, perhaps. And with the orange bars here, we can see that the proportion of patients with UFRs above 13 has declined by nearly half, from 19% in 2010 down to less than 10% in the current data. So polling question 2 asks, if the average ultrafiltration rate is declining in the unit, what reason best describes the cause? Salt and water intake restriction, longer average treatment times, RKF preservation practices, higher dry weight, or other? Well, that's a pretty balanced mix of responses. Looks like salt intake, salt water restriction, dry weight, and other were responded twice, and 4 of you responded longer average treatment times, which again sort of corresponds with data that we've seen. And in the middle, practices preserve RKF at 23%. Thank you very much for your participation there.
Doug, hi, this is Bruce. Yeah, I would just note as well that, from my point of view, the decline in UF rate has been just phenomenal in the U.S. It's been just a major achievement, and I think a lot kudos are due out to many folks who have been part of that change, and ultimately I think should be good not only for decrease in hospitalizations and adverse outcomes, but also hopefully in helping patients feel better during and after dialysis sessions. It is interesting per this poll, as Doug noted, that the reasons for this decline are probably mixed, and it is possible that some centers may be substantially prolonging treatment time. On the other hand, Doug, ultimately our average treatment time has increased just a little bit. So I think overall it's probably not a major driver of what's going on. But yeah, are folks doing better? Are folks on the line or other folks in the dialysis unit doing better with counseling folks to restrict salt intake? Are we potentially not treating down to it quite as aggressively with respect to dry weight, et cetera? But there's a lot of more work to do with respect to understanding why this is occurring. But either way, it's really a phenomenal development. Okay, yeah, Doug, thank you.
Yeah, thank you, Bruce. Moving to anemia topics. The first slide is the trend in hemoglobin distribution in our national sample. Prior to 2011, we had seen, at the beginning of 2011, just after the introduction of the revised prospective payment system, we had seen a pretty sharp decline in hemoglobin levels that had reached on the whole, nearly 3/4 of a gram per deciliter. But in the last few years, certainly since 2012, we've seen a very flat trend in the distribution of hemoglobin values. Just to orient you to this slide, the dots in the center represent the median of the distribution. 50% of patients will be above this value, 50% will be below. The upper and the lower error bars correspond to the 10th and 25th percentiles on the bottom and the 75th and 90th percentiles on the top. So you can read these numbers to suggest that 10% of patients had, in February of 2019, 10% of patients have a hemoglobin of 12.1 grams per deciliter or higher. 9.1% of 10% of patients have a hemoglobin value of 9.1 grams per deciliter or lower. And again, as I mentioned, you can see that the trend here has been pretty flat, certainly going back to 2016. But as you might see on the website, going even further back into mid-2012, values have remained approximately in this range. The next slide shows the distribution of anemia therapy prescription. This is any use of these agents over the prior 3 months. In the dark blue line on top, this is the proportion of patients prescribed any ESA. This has been very slightly declining since 2016, 91% down to 89%. Use of IV iron has actually, it looks like that's been declining in recent years as well, with 87% in February of 16, declining down to 78% in the current data in February 2019. Due to the fact that for the web conference, we're only showing back to 2016, you can see that the use of subcutaneous ESA in the non-LDO sample had been 21%. It had actually been much lower than that, but after the introduction of the bundle, we had seen a transitory increase in the use of sub-Q ESA that has now gone back, essentially the baseline, around 6% of patients using sub-Q ESA. Sub-Q ESA has never, well, not since 2010, been very commonly used in the ill kids. Next slide.
Doug and folks on the line, we'll be just a moment in just a technical issue advancing that slide. Okay, Doug, do you have it there?
Yes. Yes,
Good.
the Serum Ferritin slide. Thank you. So the increased proportion of patients using IV iron, as well as the decreasing proportion of, decreasing dose of ESAs delivered to patients using ESAs have contributed in large part to an increase in serum ferritin values. Again, here the solid line going through the middle represents the median of the distribution. You can see that in February 2019, we're seeing that the median ferritin value is now 800 nanograms per milliliter. And the 90th percentile value is 1423. These are fairly highly elevated values of ferritin, particularly at the median and above. And on the next slide. Okay. So there was a clinical trial that just came out in January in the New England Journal called Pivotal, and this was looking at the use of IV iron in patients undergoing maintenance dialysis. There were two main groups. The first was a high dose group that were getting, I believe it was 400 milligrams of iron per month, unless ferritin was above 700. And the reactive group was getting somewhere between 0 and 400 milligrams per month when ferritin decreased below 200 or transferrin saturation went below 20%. And so the main finding from this study was that the main finding from this study was that the proactive high-dose iron regimen was associated with a lower risk of mortality. And so this, I believe this was an interesting study. However, one thing that came of it was that the iron doses that are used in the U.S. and particularly the ferritin values that are observed in the U.S. were much higher than those used to define the study groups. So what are highlighted here are some sort of effective ranges for where those study parameters would have fallen with regard to ferritin. And you can see that less than 10% of patients have a ferritin value less than 200. So the bottom of that error bar, the bottom of the bottom error bar corresponds to the 10% level, and that's already at 288 in the February 2019 data. So less than 10% would be less than 288 for sure. As well, patients with a ferritin above 700 would not be scheduled to receive their monthly iron dose in the proactive maintenance dosing phase. So with the median value of 800, we can infer that more than half of patients would not have been receiving iron in the proactive arm of that trial based on U.S. data. Bruce, did you have any other clinical insights with regard to this?
Doug, yeah, no, thank you. I think just as you noted, it's quite striking, again, that the high-dose arm, which is the upper orange bar, which did have somewhat improved outcomes, actually is, as Doug notes, generally lower than what we see in many U.S. practices with a cap at dosing when ferritin levels exceed 700. And indeed, loosely speaking, perhaps half the patients in the U.S. are receiving IV iron based on protocols that are somewhat more aggressive than that higher arm. So ultimately, it's hard, in my view at least, hard to extend findings from pivotal to those folks who are receiving yet more aggressive or yet higher doses of IV iron than seen in the study. So again, a lot of folks in the U.S., I don't think we gain a ton of insight into optimal practice, into whether they are receiving optimal practice based on pivotal. And with that, we actually had a next polling question. And Doug, yeah, go ahead.
Yeah, this polling question is just very simple. Do you expect pivotal to change your practice? No, yes, with increased IV iron dose or ferritin target, or yes with lower IV iron dose or ferritin target. All right, well, it looks like most of you responded that pivotal will likely not change your practice, 66.7%.
Yeah, that's fascinating. Thanks for folks who responded to that question. Again, I think as Doug noted, the study was run in the United Kingdom, and generally we see in Europe somewhat less aggressive IV iron dosing practices, such that in Europe the typical ferritin upper limit will be 800 or in some cases 500. So certainly the McDougall study, the pivotal study, spoke very appropriately to practice, to current practice in Europe, but not per se to what's being done here in the States. So anyway, I think that's very interesting, and perhaps more to come as we follow up with a bit more time after pivotal has been out there. And as groups and the various groups, KDIGO and others that develop guidelines as they start to, over time, roll out updated guidelines on the basis of these and other studies. Thanks.
Yeah, thanks, Bruce. I just have 3 quick slides on mineral and bone disorder. The first slide is looking at the distribution of parathyroid hormone. This has been slowly increasing in trend throughout the entirety of the DPM reporting period back to 2010. The current median is just under 400 picograms per milliliter, with 90th percentile values now approaching or exceeding 1,000 picograms per milliliter. One aspect of this distribution of PTH that we've talked about many times in the past is that PTH values, of course, are higher in Black patients, and PTH values above 600 picograms per milliliter have been reported to be associated with adverse outcomes. So patients, Black patients having a higher proportion, above 600 at 33% compared to non-Black patients, has been a note of concern that we've raised over time. However, it is interesting to note that it appears that PTH values in non-Black patients are, whereas Black patients have had a fairly stable trend, a relatively stable trend in increasing PTH, the PTH values among non-Black patients have been increasing much more quickly in recent years, with now 23% of patients, non-Black patients, having PTH above 600. The use of phosphate binders has declined a little bit from 85% down to 76% through February of 2018. The use of vitamin D has stayed pretty flat, right around the low 80% range. The biggest transition that's happened there is transition from intravenous to oral forms of vitamin D, primarily from IV paracalcitol to IV doxorubicin to now oral calcitriol. And as I mentioned before, calcimimetic trend has been a slight increase over time, with about 30% of patients now using a calcimimetic. So to summarize, we talked about the recent uptake of etocalcitide in the small and independent DOs and hospital-based units, as well as the uptake of pegylated dipotent beta in that sample. We talked about a reduction in the ultrafiltration rate, and we talked about stability in hemoglobin levels with a transition toward long-acting ESAs, and that's of interest. There was a recent study that came out of Japanese registry data that suggested that the use of long-acting ESAs may be associated with increased mortality compared to short-acting ESAs, and we look forward to additional studies in the future looking at that comparison in more detail. And lastly, we talked about high PTH levels comparatively to elsewhere in the world that are still getting higher. So, thank you. I think we got one more quick polling question, just asking about other trends in in-center hemodialysis practices that are of interest. Okay, it looks like the poll has closed, and we had some responses. Patient satisfaction, rates and treatment of infection, and catheter rates. Catheter rates, if this is with regard to the use of catheters, we do show on the website a cross-sectional distribution of patients using catheter versus AV graft or AV fistula that is available on the website. And thank you for the other two responses.
All right, Doug, thank you very much. And the last question in particular helps us, as we plan for future conferences, to think about additional material to consider. We're certainly open to additional suggestions, and please contact us as wanted. Actually, and that can be done through the end of this conference. Of course, send us questions or through our website at any point as well. And we certainly do have information on patient-reported outcomes that we can begin to speak a bit more to also. So thank you very much. Actually, I think what we'll do is move on to the next segment. And Roberto Pecoits-Filho is a senior research scientist here at Arbor Research, also a professor of medicine at the University of Curitiba in Brazil. And we have the privilege of asking Roberto to speak today on CKDOPPS. I'll let him give the introduction to the study, and Roberto will highlight some important areas in practice variation and potential areas for improvement as well. Thanks, Roberto.
Thanks, Bruce. And it'll be my pleasure today to share with you some of the initial data of this that is a younger member of the DOPPS family of studies, reminding everybody that we also have an ongoing peritoneal dialysis study, and both CKDOPPS and PDOPPS are actually including patients in the United States. This is a list of countries participating in CKDOPPS today. So other than in the U.S., where 34 clinics out of a target of 40 are recruiting patients currently, Brazil, France, Germany, and Japan are also participating in this observational study that targets about 12,000 patients. Patients are mainly on CKD stages 3B, 4, and 5. Adult patients, all causes of CKD included. And each clinic participating in CKDOPPS is asked to include 60 to 90 patients per clinic with a GFR lower than 45. In general, the study in different countries are going to follow up patients for 3 years, but in the U.S. and in Brazil, we do have patients already starting to be included in phase 2, which is the second phase of the study that will continue for some time. This is the update in terms of recruitment, clinic and patients enrollment. So you can see here that in Brazil there is almost 1,000 patients included, 3,000 patients in France, 1,800 in Germany, 2,200 in Japan, and in the U.S. at the moment, almost 2,000 patients were included in 34 participating clinics. And you can see that the total number of patients today in follow-up is about 10,000, and that's very close to the target that we had in the beginning of the study. The outcomes in the study that would be mainly included in a lot of the analysis that are being done and will be done are mortality, hospitalization. A lot of patient-reported outcomes are also being captured, and progression to end-stage kidney disease is a main outcome that is being captured, and transition to dialysis, one of our main interests. So we are at the moment starting to have enough follow-up time to capture those outcomes that I described in the previous slide. But the only study that has been finalized and presented in an abstract at the European Congress last year related to progression of kidney disease and also mortality events is based on the German CKDOPPS cohort, which is one of the biggest one and the one with longer follow-up. And you can see here what we can expect from a population with moderate to severe chronic kidney disease, that a proportion of patients being followed up here for 4 years, at the end of the follow-up, they will have experienced reaching dialysis, being transplanted, or dying. But it's interesting to see here that in this nephrology practices in Germany, for patients with a baseline GFR higher than 30, only about 20% of the patients have reached an outcome. And even patients that started the study with a GFR lower than 30 on the right part of the slide, after 4 years of follow-up, about 40% of the patients were still alive and not on dialysis, suggesting that in nephrology clinics, at least in Germany, we can actually see that progression of kidney disease, even at that level of GFR, is quite slow. And death events, not as common as described in cohorts that published their data in the past. Next slide. And also, something that we learned from the German data is that the progression of kidney disease in comparison to mortality events are quite different according to the age group of the population studied. And you can see here that particularly in younger patients at the left part of the slide, after 4 years of follow-up, there is much more ESKD events compared to mortality events, when you compare it to the older population at the right part of the slide, where about half of the patients reached the SKD and the other half of the patients died. So age seems to be an important determinant of the type of outcome that you expect in that patients with moderate to severe chronic kidney disease. Now, to achieve the best results in patients with chronic kidney disease at this stage, stratification of the risk for progression and also for mortality events is very important. This could be done very easily with estimation of GFR and also with the quantification of albuminuria. So the current guidelines are actually suggesting or recommending that those two evaluations are done periodically in those patients and allow for stratification of risk. And after patients are identified according to risk, the pillars for care related to progression of kidney disease can be implemented and emphasized, particularly in patients at high risk. So there are non-pharmacological approaches that are important and recommended, like exercise, quit smoking, and the restriction of sodium and protein in diet. And also very clear recommendations regarding to blood pressure control, glycemic control, and for blood pressure control, the preferential use of RAS inhibition. All of this has been recommended by KDIGO and guidelines published already in 2012. The new thing that we have at the moment in terms of new recommendations that are coming soon are related to a preferential class of hypoglycemic agents, the SGLT2 inhibitors, that in recent trials have been associated with renal protective effects. So let's take a look at those pillars of care and how they are being practiced and implemented in different countries with a focus in the U.S. So in this slide, you can see the patient reported achievement of some of those recommended lifestyle and dietary advices according to CKD stage and country. And let's focus here on salt and protein intake, because I think in those two recommendations, there are some important information about the U.S. that seems to differ compared to European or South American data. So first, advice to reduce salt intake is actually reported by clinics in the U.S. in less than half of the patients on stage 3, 4, and 5. And this contrasts with the data in France and Brazil, where from 70 to 80% of the times patients are getting an advice of this important measure to control the progression of kidney disease and also for blood pressure control in this population. And also in the U.S., the advice to reduce protein intake is not very common. 13% on stage 3 and only 25% in stage 4 CKD. And this also contrasts with the much higher advice to reduce protein intake observed in Brazil and France. Now let's move to control of diabetes, and this data is based only on patients with this comorbidity. And in terms of HbA1c achieved in patients in CKD stages and across countries, you can see here that about a quarter of patients present with hemoglobin higher than 8, which is definitely higher than the recommended for glucose control in stages 3 and 4 and 5 of CKD. And also, it is important to notice that there is about 10 to 15% of patients in different countries and different CKD stages that also present with a low HbA1c, and these patients might be prone to hypoglycemic episodes. And only about 50 to 70% of patients are really at the range of HbA1c that is recommended for best outcomes. So lots of room for improvement here in terms of diabetes control. So this slide actually shows how different practices in different countries are being organized and delivered in terms of the diabetes treatment. And you can see here in the US, on the right part of the slide, that about 50% of patients on stage 4 and 5 and about 42 in stages 3 are actually using insulin alone. And a combination of insulin and an oral antidiabetic drug in about 20% in both stages. And the use of oral antidiabetic drugs alone is somewhere between 33 and 38% in the U.S. So the message here is that there's a large proportion of patients with insulin alone, and this might be a reflection of the options of treatment at current practices that might change as the new anti-diabetic drugs are introduced to the market and are proven to be safe and effective in that patient population. So one of the most interesting drugs that is recommended as a first line for glucose for an oral agent for glucose control is metformin. But as we all know, metformin has a limitation when it comes to the use in lower ranges of GFR. And the current recommendation is that the dose is adjusted and decreased in stage 3, and on stage 4 and 5, ADA and also KDOPPS actually recommend the discontinuation of metformin. And you can see here that this is actually a practice that varies very much across countries. In countries like Brazil, for instance, about 25% of diabetic patients are managed with metformin at very low ranges of GFR, in contrast to the US, where only 2% of patients are actually being prescribed metformin at a GFR lower than 30. This might reflect different beliefs in different countries about the safety of the drug and also perhaps the availability of different oral agents in different countries and for distribution in public healthcare systems. So that leads to the first polling question of this part of the presentation today. And now I would ask you what hypoglycemic drug, and I ask you to choose one, do you think should be prescribed more frequently in patients with diabetes and moderate to advanced CKD? Is it metformin, insulin, DPP-4 inhibitors, GLP-1 agonists, or SGLT2 inhibitors? I'll give you a few moments to answer the question. That's very interesting because as you probably heard or read, SGLT inhibitors are actually becoming very popular because it's potential renoprotective actions, and they might be included in the recommendations as a first-line therapy for those patients. Next slide. So very briefly, I want to touch base on a couple of final issues related to blood pressure and also the renin-angiotensin system inhibitors. This is for blood pressure, and remember the guidelines are recommended targets of 140/90 or 130/80 in patients with albuminuria. And you can see here in the U.S. at the right part of the slide that actually there is a very low number of patients that are actually achieving what the target is currently recommended. And also particularly interesting is the fact that the patients with albuminuria in green are actually achieving the target blood pressure at a lower rate of the other patients with no albuminuria, which is actually the opposite of what you would be expecting to achieve the best outcomes. Finally, we can just briefly take a look at the use of the recommended preferred treatment for blood pressure control, which is the RAS inhibition. And here you can see, again, focusing on the US data on the right part of the slide, that there is a very low use of RAS inhibitors in all stages of CKD, but particularly in the transition between 4 and 5. And you can see here for the US that less than 40% of patients are being prescribed this class of drugs. Reasons for that are not very clearly understood, but you can see here that hyperkalemia might be involved in that. And you see that about 30% of patients on stage 5 in the US are presenting a baseline potassium level higher than 5, and this might be one of the reasons for this limitation in the prescription in this country. Maybe we'll skip for the sake of time the last polling question, and I'll pass it back to Bruce for the final part of this presentation.
So thank you so much. A lot of excitement in the treatment of advanced CKD in recent months, and this is just great after many years of not a whole lot of advances, a lot now to think about. So stay tuned, and we'll be sure to present updates moving forward as well. We have 3 more slides that Mark Newman will present. Mark Newman leads nephrology issues, part of the Helio group as well. And Mark is just a wealth of knowledge with respect to policy in the ESRD space. And Mark, let me pass things on to you. Actually, just in the interest of time, and Mark, again, thanks for helping put these questions together. As many folks on the phone will be aware, there's also a lot of excitement these days with respect to reimbursement policy and sort of starting to rethink or potential changes to reimbursement as the CMS in particular starts to rethink its approach to dialysis and it's the focus moving upstream, as it were, to folks with advanced CKD as they progress to kidney failure and may or may not start dialysis or receive transplantation at that time. So our first polling question related to this, there's a lot of interest on the part of CMS in greater use of home dialysis. In particular, they've indicated they would like to see 50% of ESRD patients on home dialysis. What do you think is a realistic percentage? And we'll give you just a moment or two to respond. Okay, great. And again, thanks for responses. And actually a sizable majority suggested between 20 to 30%. And that seems to me like that's a really interesting number to estimate, and perhaps is right on. Actually, at this stage, we're in the range of, let's say, 12% or so, with, of course, the majority, over 90% of that being peritoneal dialysis. So if indeed we were able to double that, that would be a substantial achievement. That really would be great news. Okay, thank you. And then we had one other question. This relates to Kidney X. So this is a new public-private partnership called Kidney X, and this aims to accelerate innovation in kidney disease treatment, specifically with a focus on devices. What, in your view, what aspect of dialysis treatment needs the most improvement? Is it in-center dialysis machine technology, home dialysis machine technology, monitoring, for example, drug delivery mechanisms, pharmaceuticals, or clinical research? And we'll give just a moment. Okay, good. Thank you very much. So that was kind of all over the place in this regard, and noted here, focus on clinical research kind of broadly, as opposed to specific focus, for example, on dialysis machine technologies. Anyway, so that's just great to hear. So thank you. So next slide, please. Okay, we're actually right at the very top of the hour. So again, a lot of excitement, not only in treatment of advanced CKD, but also in progression and start of progression to kidney failure and ways to manage folks who have just developed kidney failure, both on the pharmaceutical side, but also the payment model side, as well as more innovative approaches to care, broadly speaking, and care management. So really a lot to look forward to moving forward. Thank you all for joining us. Our next update will be to the DOPPS Practice Monitor. We'll be in 6 months with data through the end of August. And we'll have a webinar, our next webinar will be in October to follow this up. If you would like to re-listen to our WebEx or download slides, please go to the web link as noted here. And thank you all very, very much, and have a great afternoon.